everyone, welcome back to Hands-On Skills. My name is Alex Like, and today we're going to be talking about placement of the Combi Tube. This device definitely is a throwback. A lot of agencies have pretty much phased this out, but there are still agencies out there that may use these devices. It's still certainly part of the curriculum that we teach with at my university, so I'm obligated to tell you at least a little bit about them. So the Combi Tube was one of the first more successful supraglottic airways, and supraglottic just means that, again, it is not sitting directly in the trachea, or at least it shouldn't under most circumstances. But you'll find that this piece of equipment, I think, is a little over-designed and over-engineered. But because it is supraglottic, this is a blind insertion device, which means there's very little training involved, and it's pretty easy to insert by an experienced provider. At this point, too, they're very, very cheap, they're inexpensive, they're easy to obtain, and they're fairly reliable if you know what you're doing. Unlike our more contemporary supraglottic airways, there are quite a few contraindications for use of the Combi Tube. One of them is the patient's age. Now, this device is not intended for use in patients who are under 16 years old. So there's one size of this device. You have to be almost an adult by age standards. And then you also cannot be under 5 feet tall for this to be used. So you have to be a certain height and you have to be of a certain age for this to be used. It's not designed to be used in pediatrics or infant patients. Your other more modern supraglottic airways, there are pediatric sizes that are available, not so much here with the Combi Tube. Now the Combi Tube, I'd mentioned it was a little bit over-designed and over-engineered, and that's because, as you'll see in the next picture, if you've never seen one of these before, there are 2 lumens. It's intended to be placed in the esophagus, as most supraglottic airways are, with the air being vented into the laryngeal inlet. However, if you somehow manage to miraculously blindly intubate the trachea, you can use the distal end of this device to actually ventilate the trachea. It's very, very uncommon for this to happen, as most supraglottic devices manufacturers know, and the modern versions of supraglottic airways don't allow you to ventilate through a distal tube. But the Combi Tube was one of the originators, and they wanted to allow for any sort of contingency, I suppose. So this hulking mass of a device is your Combi Tube. Now, like I'd mentioned in the last slide, there are 2 lumens present here, and as you'll see in the insertion video, you're expected to test both of them out in order to determine where you ended up putting this tube. Just like our other supraglottic airways, there is a cuff that is designed to kind of obstruct the oropharynx to prevent air from coming from above. And there's a distal cuff here. This will actually prevent gastric contents from coming up. However, because there's a distal end here, that distal end connects to one of your lumens, and if you don't begin suctioning that esophageal lumen right away and the belly is full, you will get vomit pointed up at you. So a lot of the times you have to incur an extra piece of equipment. You have to place like an orogastric tube down into that esophageal lumen and actually decompress the stomach, in addition to regularly ventilating this patient. If you place this properly, if you place this correctly, when you're ventilating the patient, you have the air that's directed out of these little perforations here and the side of the tube pointed directly at the larynx, and that's in the ideal placement. Pilot balloons, there are 2. Unlike your other devices, these inflate each balloon or each cuff separately. And then the most important thing here is your depth lines. These are important because this is a one-size device, so you have to place it in a certain way in order for it to be effective. With the Combi Tube, you want to be placing the teeth in between these 2 lines. So you have not inserted it far enough until the teeth end up in between the 2 lines here. If your teeth are down here, you need to keep pushing it. If your teeth end up way up here, you need to pull it back. So your teeth must end up between those 2 lines. little cross-sectional view here of the Combi Tube when it's inserted where it should be. So in this case, this is your ideal placement of the Combi Tube. It's gone where it was designed to go. You've got the distal cuff sitting neatly in the esophagus down here. Proximal cuff is where it should be in the oropharynx or the hypopharynx. And then your air is being directed straight at the larynx from those little perforations in the side of the tube. Now, because this was designed to potentially be put directly into the trachea, if this tube were to end up somehow miraculously in here, this end on the bottom of the supraglottic airway is open and you can ventilate through that. So you would ventilate just like you'd be ventilating through an ET tube. Because of that though, because of that extra option, you've got 2 lumens now that you've got to navigate, and we'll talk about that in a minute, or I'll show you that in a minute. And then of course 2 pilot balloons, and they are color coded to the particular lumen or the particular cuff and lumen combination that you'll be ventilating through. And this will make a little bit more sense as I show you the insertion. Let me show you how they're put in.
So the first thing you want to do, of course, is check responsiveness. Once you've determined that they're unresponsive, you're going to go ahead and size and place an OPA. I'm measuring here from the corner of the mouth to the tip of the earlobe, and I'll be placing this with just a standard tongue depressor. Once that's in, I'll begin ventilating with a BVM, 1 breath every 5 to 6 seconds. I'll connect this to oxygen and make sure that the patient is also on a pulse oximeter. I'll pass this off to a partner who will continue to ventilate for me while I check my equipment. Now, the Combi Tube has 2 cuffs to it and 2 actual airway lumens. These cuffs have independent balloons. There's a small balloon which will take approximately 12 to 15 mLs, and that's the distal cuff. That one ideally will end up in the esophagus. The larger proximal balloon will take approximately 85 to 100 mLs of air. Sometimes this one's a little bit more challenging to fill up. This cuff will sit in the oropharynx. I'll just leave these attached so I'm not fumbling around for syringes after I've placed the device. Make sure to apply copious amounts of water-based lubricant to this device. And once you're ready, remove the OPA, grip the jaw, and insert it until the teeth are between the 2 black lines. Once that's in, go ahead and inflate the proximal larger cuff first, and then inflate the distal esophageal cuff second. Now we'll test both airways. We'll test the blue proximal airway. This should be the one that is placed correctly. So this one is directing air at the trachea itself, and I'm listening for lung sounds here, and I'm hearing them. And then we'll check the more distal airway lumen. This one, if it's placed correctly, should be in the esophagus, so the only thing I should be able to hear are gurgles in the stomach. Once I've identified the correct lumen, I'll go ahead and place end-tidal capnography on it. And I'm looking for normal values here, 35 to 45 millimeters of mercury. And I will secure this device in place with a tube holder. And now my device has been properly secured. I will continue to ventilate.
All right, well, that was placement of a Combi Tube. I hope you got something out of that video. As always, please continue to stay safe and wash your hands. I will see you next time.